of your seeing the improvement of the prognosis of the patient. If you are treating and this titer is decreasing, it means your patient is improving. If you are treating and this has been vanished, means your patient has now been cured, and this will remain positive lifelong, so we don't have to worry. So we have known one condition where this can be non-treponema test can be negative, but this will be positive lifelong. This is after treatment. This can help with the false positive result, pregnancy, viral infection, drug, rheumatic fever, lupus. This non-specific test, you don't have to confuse in that situation with the syphilis. You can do the specific test and that will be negative, because it is not due to this. This condition has led to positive for non-treponemal test, but that is not due to treponema pallidum, so a specific test will be negative. There is another situation where non-treponema test can be negative, but still patient has disease, that is called Projon phenomena. We dilute the serum, and in that situation, after dilution, when optimum antibody and antigen condition will be appropriate, then there will be the flocculation or clumping occurs, and the diagnosis will be again confirmed. So hope you have understood all the aspects of your diagnosis, all the interpretation of your test, so that you can clinically evaluate your patient in which situation your patient is. Let me get to you this Kaplan microbiology, where we are talking about the spirochetes. So we are talking about the treponema pallidum. Treponema pallidum, these are the thin spirochetes, not reliably seen on the gram stain. Basically a gram-negative cell envelope. Outer membrane has endotoxin-like lipid, axial filament, endoflagella, periplasmic flagella. They cannot culture in the lab. Serodiagnosis, it is an obligate pathogen. Human reservoir, genital tract is the human reservoir, transmitted sexually as well as across the placenta. So every pregnant woman need to be treated, because this cross the placenta only after first trimester. So you have a window of 3 months to treat your patient. So every woman, because they can transmit to the baby and they will develop the congenital syphilis, and you have seen the congenital syphilis have a severe complication. So baby will have a complication that can be prevented. So screen a patient, woman, every woman, antenatal care, and if you find diagnosis, and then treat it. Penicillin is not contraindicated in the pregnancy woman. Pathogenesis, disease characterized by the endarteritis resulting the lesion, strong tendency to chronicity. So the main VNIAC, you have to understand that sexually active patient or neonate of IV drug using female patient. So this will be your condition leading to you, giving you a scenario. So there must be a sexually active female or male to get this disease. They can be a pregnant woman that can be an IV drug user, and then neonate will develop congenital syphilis. Primary, non-tender, indurated genital chancre. Secondary, maculopapular rash, including palm and so, color rash, condyloma lata. Tertiary, there is the gumma in the CNS and cardiovascular system. These are spiral, gram-negative bacteria visualized by dark field or fluorescence antibody. Specific and non-specific serological tests are there. Specific, non-specific are BDRL and RPR, where they will give you RPR, and specific is FTABS or say TPSA, TPPA. Stage of syphilis, there will be a primary, 10 days to 3 months, non-tender chancre, clean, indurated age, contagious, heal spontaneously after 3 to 6 weeks. Diagnosis, fluorescence microscope, 50% will be negative by non-specific serology. Secondary, 1 to 3 months later, maculopapular rash, diffuse, included palm and sole, patchy alopecia, condyloma lata, flat, warty-like perineal mucosal membrane, lesion, highly infectious, serological, non-specific and specific, both is positive. There can be latent syphilis, late latent, early latent and late latent. There will be no symptom at all, but in serology you find the positivity. In tertiary syphilis, 30% of untreated years later, gummas develop, that is syphilitic gummas, aortitis, CNS inflammation, that is stapes dorsalis, that is damage of your anterior column of the spinal cord. Serological, specific date, non-specific may be negative. Congenital, baby of the IV drug using. There can be stillbirth, keratitis, deafness, nose teeth, most born asymptomatic or with rhinitis, widespread discriminating maculopapular rash. Serology should revert be negative within 3 months of the birth if infected. So we can do a serology, and that can be revert to negative within 3 months if it is not infected. Diagnosis, you can directly demonstrate organism. We have talked the detail, visualize organism by immunofluorescence or dark field microscopy. Even PCR can be done. Serological, do 2 tests, non-treponemal test and treponemal test. Non-treponemal is that's bind to the cardiolipin. We have the combination of 3, and that is BDRL, RPR, and even ERT. There are the different, this is recombinant antigen test. So there are automated reagent test. Venereal disease research lab, RPR is rapid plasma reagent, automated reagent test is ERT, and recombinant antigen test is there. Specific treponemal tests are like TPHA, FTABS widely used. So that is you have to understand. Earliest antibodies bind to the spirochetes. These tests are more specific and positive earlier, usually remain positive for life, but positive in those with other treponal diseases like basal may be positive in Lyme disease. So non-specific positive tests should also be ruled out. And then fluorescence test antibodies more commonly used. Treatment is just give the benzathine penicillin long acting for primary and secondary syphilis, penicillin G for congenital and late syphilis. There is another reaction called the Jehrichs-Hexmer reaction starting during the 24 hours of antibiotic treatment. There is increased temperature and decreased BP, rigors, leukopenia may occur during the treatment of any spirochetes. So this is just a reaction. When you give a treatment, the bacteria starts to die and then release the toxin, and because of that you have started the fever, you have a decrease in BP, rigors that is there, leukopenia may occur, and these are just a reaction of the dying bacteria, you can remember in that way. So prevention, benzathine penicillin can be given to contact, no vaccine is available. So hope you have also understand this Jehrichs-Hexmer reaction, flu-like symptom like fever, chill, headache and myalgia after antibiotic are started due to the host respond to the sudden release of bacterial antigen. So when you start the antibiotic, the bacteria will start to die, so they will release some of the antigen, and because of that there will be a reaction inside your body, and that is known as the Jehrichs-Hexmer reaction. This is the flu-like symptom. Hope you have understand, and now you will be able to clinically diagnose all the stages of your syphilis and treat the patient in an appropriate way, and can deal all the question in any scenario in any medical entrance exam all over the world. Thank you.